Hello, I'm Dr. Ed Ashwood. I am the Medical Director of Maternal Serum Screening and Professor of Pathology at the University of Utah. My topic today are current approaches to maternal screening. ARUP has great depth in maternal serum screening. We established our program almost 30 years ago. Since then, we've tested 1.4 million patients. We have written many papers in the prenatal literature over the last 30 years, as well as chapters in textbooks. Also, we've been responsible for helping write guidelines on this topic and giving lectures worldwide on this topic. Finally, we've also served for several years on the College of American Pathologists Resource Committee, which establishes proficiency testing for maternal screening. Also joining us in this program are tremendous genetic counselors. We've had genetic counselor support since the program began, and they help us with weekly meetings and setting policy. Our counselors have been very involved in performing specific studies that relate to maternal serum screening. And finally, they also help teach genetic counseling students. The students rotate through our lab and learn about the principles of screening. A big issue that is facing maternal serum screening is whether or not to use cell-free DNA in low-risk women, period. The original professional guidelines published by most of the professional societies recommended cell-free DNA screening only for high-risk women. This, however, is evolving rapidly. For example, in 2015, the International Society of Prenatal Diagnosis issued a recommendation that cell-free DNA could be used as a primary test for all women at 10 weeks of pregnancy. Likewise, the American Congress of Obstetrics and Gynecology changed their guideline in February 2015. Their recommendation states that although any patient may choose cell-free DNA screening, that conventional screening methods remain the most appropriate choice for low-risk women. Let me review conventional screening and cell-free DNA. The oldest and most conventional screen is the single alpha-fetoprotein for neural tube defects. This is done in the second trimester. It has a detection rate of anywhere from 85 to 90% and a false positive rate in our hands of 1.5%. Our most popular Down syndrome screen is the quad screen. It's available in the second trimester. It has an 80% detection rate with about a 5% false positive rate. We also offer a first trimester combined screen with a similar detection rate and false positive rate to the quad. The integrated test is available for those women who want a higher detection rate and a lower false positive rate. We calculate that the detection rate on our integrated screen, which includes, of course, a first and second trimester specimen and an ultrasound measurement in the first trimester, that detection rate is 90%. Our false positive rate is 2%. For those women who want better detection and low false positive rates but want an earlier answer, we offer the sequential screen, which is a combination of the first trimester combined screen and the integrated screen. The detection rate is quite similar, and the false positive rate is slightly higher, 2.5%. The newest test for screening is cell-free DNA. It's available in the first trimester and early second trimester. It has a very high detection rate, greater than 98%, and a false positive rate of about 3 per 1,000. Now, several of our screens rely on an ultrasound measurement called Nuchal Translucency. This is performed by sonographers and sent in to the laboratory. It's very important that the sonographer be well trained to do this. They need to have a consistent measurement. We need to see an appropriate rise with gestational age and an appropriate amount of scatter. Sonographers, however, differ quite a bit. They're supposed to measure the crown rump length and at the same time that they measure the nuchal translucency. We QA each sonographer in our programs. The CRL is plotted on the x-axis and the NT is plotted on the y-axis. For QA measures, we look at the slope, the scatter, and whether or not their NT measures agree with those that they've been getting in the past. We can judge this by looking at the NT multiple of the median, which should be close to 1.0. Here's an example of a sonographer that shows a good slope and good data with a nice scatter about the regression line, which is shown here. We use sonographer-specific medians, which allow us then to compare their current measurements to their prior measurements. When we get a new sonographer into our program, we ask them for between 20 and 50 prior cases, and we perform the regression analysis ourselves to establish their slope and intercept. Some sonographers are not able to provide us with that data. When that happens, we use a group median equation. As soon as we've accumulated enough data to switch to a sonographer-specific data, we do. Now, why is that important? Well, let me show you what happens when you don't use sonographer-specific data. And realize that these sonographers are using different equipment and slightly different techniques. In fact, I like to tell people that sonographers are similar to having an individual instrument for each of these ultrasound measurements. Here's the data from a sonographer that's in our current program. Notice that this data has an upward trend and has very little scatter, but is entirely acceptable for making NT measurements. In fact, here is the median equation we've established for this sonographer. Now, if we use these sonographer measurements and compared them to the median that we had for the other sonographer that I just showed you, we would have this trend. As you can see, almost all of the data is above the median line. All of the values would be high, higher than you'd expect them to be. So this would introduce bias into the screen. Now, is that bias important? It really is. The false positive rate that you'll see if you overestimate the nuchal translucency by as much as 0.5 millimeter is quite substantial. In fact, the false positive rate can easily double. Another aspect to our program is great turnaround time. For our sequential test in the first trimester, you can see that these are our turnaround times prepared graphically. This is from collection of the specimen until verification of result. You can see that a little over 24 hours is required to get some results out, but about half of the results are back a little over 2 days into past collection. And then by 3 days and 4 days, we have almost all the results back to the provider. Delays in testing are usually attributable to incomplete information provided to us. The second trimester analyses are very similar. Here is the graph for the sequential test results from the second trimester specimen. And as you can see that we have most of these back in 4 days. We're also continually looking at ways to do better testing. So if you look at the traditional biochemical testing, if you're normal, you just stop. If you're abnormal, you go on to diagnostic testing. With CellFree DNA, you do a similar thing. If you're normal, you stop. If you're abnormal, you go on to diagnostic testing. It is possible to change this paradigm and move the CellFree DNA screening to be a secondary screen following the traditional abnormal screen from the biochemical testing. This could greatly reduce false positive rates for diagnostic testing, as well as improve the detection rate that one sees. In conclusion, what ARUP brings to prenatal testing are sonographer-specific medians, which very few labs perform. We also allow clients to choose their Down syndrome risk cutoff and their alpha-fetoprotein MOM cutoff. The client can also decide if they want to have abnormal results, either faxed or phoned directly to them. ARUP has weekly meetings where we review the medians, we discuss interesting cases, and we decide on changes that we'll make in the program. And then finally, we're renowned for our quick turnaround times. Thank you for your time today.